So we are ready to move on to our third presentation for the day. This is minimizing symptoms and maximizing quality by focused symptom management in the outpatient setting,
which is being presented today by Drs. Sarah Hoehn and Amy Wang of the University of Chicago Coleman Children's Hospital.
Dr. Hoehn is a board-certified pediatrician with expertise in ethics, hospice and palliative medicine, and critical care medicine. She divides her clinical time between pediatric intensive care unit and running the pediatric supportive care team, which includes palliative care, hospice care, pain management, and complementary medicine. As a part of the complementary medicine program, Coleman Children's Hospital has massage services available to patients and their families. When Dr. Hoehn is not caring for children in the hospital, she does research on the impact of stress of families and children whose children are critically ill. Her long-term goals are to find novel ways to support families who have critically ill children. Dr. Wang is a third-year fellow in hematology oncology at the University of Chicago. She completed her MD at the University of Texas Medical School in Houston and an MPH at the University of Texas School of Public Health. She then completed her residency training in internal medicine and pediatrics at the University of Chicago. Her clinical interest is in hematologic malignancies with a particular focus on the care of adolescent and young adults with acute leukemias and lymphomas. Her research has been focused on supportive care and survivorship issues in AYAs with hematologic malignancies. So thank you both for joining us today, and I introduce or I welcome you both, Dr. Hoehn and Dr. Wang.
Thank you so much, Betty. I am so excited to be virtually here today to discuss what we've been working on in our AYA clinic. And let me just make my screen full screen here. Okay. All right, hopefully everyone can see my screen. And again, thank you so much for the invitation to speak today. I'm really excited to give this joint talk with me and Dr. Hoehn on minimizing symptoms and maximizing quality by focused symptom management in the outpatient setting. And I have no disclosures, and Dr. Hoehn does not have any disclosures either, although she will discuss some off-label indications of medications. So some of the objectives that we're going to cover today, I'm going to start off the talk by discussing some evidence for early palliative care integration, its limitations as well as its challenges. I will segue into describing our AYA experience with measuring symptom burden and integrating palliative care. And then I will hand over the virtual microphone to Dr. Hoehn, who will discuss some of the outcomes within our clinic with this study and following up with several symptom scenarios that we commonly encounter in our patients. And then finally, we're going to conclude by discussing a standard approach to integrating palliative care that can be utilized to address health disparities, which I think is definitely a very apt topic in the post-George Floyd era. So I want to start by defining palliative care, given the broad range of audience we have. And this is a definition that is used by ASCO, which is, palliative care is a patient and family-centered care that optimizes quality of life by anticipating, preventing, and treating suffering. Palliative care throughout the continuum of illness involves addressing physical, intellectual, emotional, social, and spiritual needs, and to facilitate patient autonomy, access to information, and choice. And I would say that this is a very all-encompassing definition, but what does that actually translate to in the clinic itself? Well, these are some of the components of palliative care, which primarily does focus on this relationship building aspect with patients and caregivers. Another key critical aspect is the symptom, distress, and functional status management, as well as exploration of understanding about illness and prognosis. And here I want to make a comment that usually the discussion of disease prognosis is made by oncologists. However, I think what I've seen commonly is that palliative care specialists can add an additional aspect of context and have that discussion of prognosis be relatable to the patient and their life goals. In addition, palliative care can help with clarification of treatment goals, coping needs, medical decision-making, care coordination with other team members, as well as referrals to other teams if needed. And so what is the role of palliative care in oncology? Well, this has been an evolving field starting over 10 years ago, where there has been multiple large randomized clinical trials that have been published within the field of adult oncology to look at the role of addition of palliative care to usual oncology care. In addition, these studies have also looked at early integration of palliative care versus delayed palliative care in both advanced stage patients as well as early stage patients. And here, palliative care is most common, or early palliative care is most commonly defined by the involvement of the palliative care team within 8 to 12 weeks of diagnosis. And what some of these studies have found is that early palliative care does lead to an increase in patient quality of life, decrease in depression, and does ultimately improve overall survival. And one of the most pivotal studies was the Jennifer Temmel study, which reported an overall survival benefit in early palliative care for patients with metastatic non-small cell lung cancer. And these patients who have received the palliative care do tend to have a better understanding of their prognosis. And so this does lead to less aggressive end-of-life care and greater satisfaction with the care received. And so because of these results, the American Society for Clinical Oncology has published guidelines calling for the integration of palliative care into standard oncology care. And this was initially published in 2012, but a revised update was published in 2017. And since then, there have been varying models of care, but the most successful ones tend to be a consultative model with both inpatient and outpatient components. However, there are many limitations, which is that most of these studies do focus on adult patients with solid tumors, and the patients with blood cancers are not very well represented. And unfortunately, there's very sparse data in pediatric oncology and also within the AYA realm. And groups that have attempted to address this have had encountered many multi-level barriers to integration of palliative care. And lastly, the mechanism by which palliative care does lead to all of these outcomes is not very well understood and is also the subject of further research. So with all of these benefits of palliative care, I think that all of us can benefit from a dose of palliative care in our lives. But unfortunately, this actually gets to a central issue, which is that there just aren't enough palliative care specialists to see all the patients who may potentially benefit. And so this gets to the first issue of the need to identify a target high-risk patient population, typically with high symptom burden and high unmet needs. And these patients most commonly do have advanced or metastatic disease, but the studies, published studies, have demonstrated improvements in some patients with early stage cancers. And secondly, regular symptom monitoring is critical through the use of either brief clinical screeners when they're in clinic or digital monitoring through a patient portal. However, I think what really needs to be emphasized is that any of these interventions has to be seamlessly integrated into the clinic workflow, otherwise they would not be very sustainable. And then lastly, referral triggers are needed, because even though we can identify a high-risk patient population, these patients may not always be in need of palliative care. And so it's important to identify the who as well as the when of when palliative care is actually needed. And so the published studies have used several common criteria, which are listed here. But I think this really does emphasize the need for all providers to be able to at least conduct a basic palliative care assessment and have basic treatment skills and to refer to the specialists when the need arises. And so I would argue that our AYA patient population is that target high-risk population. Multiple studies have demonstrated that these patients report high distress and low quality of life. One specific study looking at distress in AYAs with hematologic malignancies do report very high levels of post-traumatic stress, depression, and anxiety. And in a study on health-related quality of life, I want to draw your eye to the chart on the graph on the right, which the researchers enrolled newly diagnosed AYAs with all cancers. And they filled out a short form 36, which is a health-related quality of life instrument with a physical component score and a mental component score. And the takeaway message is that at diagnosis, unsurprisingly, these patients do report low quality of life as compared to a normative population. And the scores do improve over time, but they never correct to normal, which just speaks on the issue of low quality of life. And as Dr. Roth had discussed, symptom burden is something that has not been very well described in AYAs, and there have been multiple efforts to develop validated screeners in order to characterize this. And then lastly, providers are not able to accurately identify distress and unmet needs in patients. According to another study. And so this gets back to the importance of regular symptom monitoring and identify these triggers. And so what do we know about the role of palliative care in AYAs with cancer? Unfortunately, very little. However, just like pediatric oncology patients, there unfortunately remains a stigma in palliative care as being synonymous with end-of-life care, and this has limited referrals. However, there has been no evidence to date that referral to palliative care changes hope or affects increases distress in AYA patients. And those patients who have received palliative care, which usually the team is brought in towards the end of their life, they do receive less intensive end-of-life care. And there have been multiple national institutes that are calling for AYA palliative care research as a priority. And so I think what this really means is that there really needs to be a shift in how we conceptualize palliative care away from that being end-of-life care and more towards palliative care as being symptom management experts in helping to relieve the suffering that patients endure, regardless of the curability of their disease. And so this gets into the potential research gap, which is that integration of early palliative care in AYAs with cancer really has not been done. And these are some of the goals that potentially could be achieved with integration. And so we decided to tackle this question through a research study conducted within our own AYA oncology clinic at the University of Chicago. This is a feasibility study with the primary aims to characterize symptom burden and to integrate palliative care in a population of AYA patients with acute leukemia and lymphoma. And this is a collaboration between our oncology team and Dr. Hoehn's pediatric supportive care team. And here I use supportive care as a more encompassing term than palliative care, because her team also includes services such as acute pain services and integrative medicine like massage and aromatherapy. And so these patients filled out validated instruments across multiple domains here that have been previously utilized in the literature. And this is what we found. So out of the 46 patients who were offered the survey, 31 patients completed the survey. And these patients are mostly undergoing treatment, but there have 16% of these patients are in survivorship. And what we found was that in our symptom screener, 100% of patients had fatigue, and about half of these patients reported one severe symptom, which is a score of 7 or higher out of 10. And these patients reported anywhere between 1 to 7 severe symptoms, with the poor feeling of well-being as the most common severe symptom reported. And in our distress screener, this is pretty consistent with the literature. About half of our patients also screened positive for distress. And not surprisingly, with health-related quality of life, AYAs do have lower quality of life, with no difference between gender or treatment status. And quality of life was statistically significantly associated with distress, financial toxicity, low spiritual well-being, and also reported the presence of pain, nausea, and depression were the symptoms that most positively predicted for low quality of life. And so here, the data I would say is not very surprising, but it serves as a proof of concept for our AYAs being a high-risk patient population, but also the ability to at least attempt to characterize their symptoms. And so this is our integrated supportive care model in our clinic. We physically brought in Dr. Hoehn and her team to form a joint oncology and supportive care clinic. And in our clinic, initially, we enrolled patients or we referred only patients who were enrolled in the symptom burden assessment study. However, it quickly became apparent that there were patients who were not on the study who also had supportive care needs. And so essentially everyone saw supportive care at some point. And so with our integrated clinics, we had the advantage of being able to do warm handoffs, the ability to have same-day evaluations with the ability to address acute issues. And then outside of clinic, the supportive care team can follow patients based on their discretion and need. And we do communicate on a weekly basis with their team. And then this here are some pre-existing services that are available within our AYA clinic to support our patients. And so some of the pros of this model is that, since everyone is receiving supportive care, it decreases the stigma. It's a one-stop shop for patients. They don't have to go anywhere, so it's easy for them. They receive timely care, and it does enhance communication. But some of the cons is that these providers do have to align their schedules, and it worked out for us, but maybe logistically not feasible for other places. And we're still hoping to bring back some of the integrative medicine services, which were temporarily stopped due to COVID. And so at this point, I want to hand the microphone over to Dr. Hoehn.
Thank you, Dr. Wang. That's our favorite slide of life with palliative care, the elephant in the room. And I want to thank Dr. Wang for this opportunity to present these slides. And this has been an amazing learning experience for all of us. So you heard from her sort of why we think it's important. And then we'll talk a little bit about what we actually did. If you want to go to the next slide, Amy. So this is sort of an overview of who we saw. And from a practical perspective, when I would introduce myself to patients, I would really say, hey, I'm Symptom Sarah. Like, that's why we're here. We want to focus on symptoms. We're with the supportive care team. And then we went through sort of different sort of prompts and different questions to see what they were experiencing. The most common things we saw were pain, anxiety, neuropathy, insomnia, and muscle cramps. When we looked back and did an analysis of 6 months worth of data, we saw that in 50% of the patients, so about half of the patients that we saw, it resulted in some adjustments to their medical management. And certainly the other half, it means that we didn't do anything at all other than just provide them support. And there was a high level of interest in non-pharmacological remedies. Amy mentioned our supportive care program with integrative medicine and massage therapy. And we also have aromatherapy based in the clinic. So a lot of people were I'm happy to, see the role of peppermint in nausea, or lavender for relaxation. So I think we were able to do some of the really easy things, which at least set the stage for a positive association with palliative care. Someone came, they gave me some lavender, life was good. So you can see that we saw about 30 patients. They were relatively young, with an average age of 29, and pretty evenly split gender-wise. In general, the majority of people I saw were on treatment, 93% of them, and only a couple on survivorship. And happily, most of the people in survivorship are like, yeah, know who you are, don't need you. But at least they knew that there was someone there if they needed it. Maybe next slide. And then we just went through some of the different things that we did in addition to giving out the aromatherapy. So a lot of times when we addressed pain, we would just add some clonidine. Clonidine is pretty beneficial. It's similar to Precedex, which we use in the ICU, but it works centrally by decreasing a neurotransmitter called substance P. So it actually decreases the awareness of pain centrally working through the bloodstream. So it's a really easy thing to add if patients tolerate it, that can help with pain. We had a lot of patients that were already on Lexapro or different things, but in some collaboration with the adult psychiatry team, we found that we were able to figure out sort of our own algorithm for patients who are having sort of refractory anxiety and depression, and then we would switch them to mirtazapine. As everybody here knows, with neuropathy, there's gabapentin, there's Lyrica, but we would sometimes add the clonidine or other medications in addition to addressing any dose changes with vincristine. With insomnia, to me, this was sort of one of the most challenging things, because there's the patients who have difficulty going to sleep because their mind is racing, they're having anxiety, which is sort of a different thing than the patients that wake up at 2, 3, 4 in the morning and they can't go back to sleep because of a discomfort symptom. Maybe they're in pain, maybe they're having cramps, maybe they're having anxiety. And really figuring out what's waking them up and what's keeping them awake, and then really trying to target the symptoms to that. I think we were surprised to see how many patients had muscle cramps, and then that's the number with depression. We can go to the next slide. So we thought what we would do is go through 3 clinical vignettes, just giving you examples, because I think a lot of people are like, what does this mean? You say you do supportive care in clinic. Well, what does this look like and what does this mean? So one example is we had a 32-year-old woman who had new onset leukemia and really bad muscle pains and cramps. And at times she wasn't able to walk, she wasn't able to sleep. She was sort of bedridden in fetal position and not able to take care of her young children and things like that. So we did start her on some low dose baclofen, and then we were able to use magnesium both to help with sleep and cramps. And then about a month later, she was doing a lot better and we were able to wean her down. And so I think one of the other things that we've seen is that magnesium is really a natural thing for people who are looking for sort of the least intervention. Magnesium can help with that, muscle cramps, and constipation. So, and when we do that, we either use magnesium sulfate or magnesium oxide. Next slide. So then we had another one who was a 37-year-old gentleman with ALL on vincristine who had really severe neuropathic pain. And he was really, really frustrated. He's like, you know what? This isn't who I am. I'm angry. I don't feel good. I'm fighting with my wife. Like, he really felt like the pain and difficulty sleeping from the pain and anxiety sort of factored everything into everything and even like changed his personality. So for him, we made some changes to the gabapentin. We went up on the clonidine. We started a little bit of clonazepam because it can be longer acting and not necessarily induce tolerance as quickly as Xanax or something like that. And then we even gave him some purine olanzapine. I'm like, I'm sorry, if you feel like you're going to punch a hole through the wall, we need to do something else. So take this oral dissolving tablet instead of punching a wall. But we learned some important lessons from him. One, which is that these patients are very gentle or very sensitive. So we had to do gentle dosing. He did come back 2 weeks later and he's like, oh my gosh, I feel amazing, but like so amazing. We're like, oh, okay, we'll cut back a little bit. So live and learn, live and learn. But I think it was a good example that, you know, ginger, gentle dosing, but you want to look at how the symptoms are impacting their quality of life. Next slide. And then this was a 25-year-old with ALL who's now in maintenance therapy, who's doing well, going back to work full time. And she's really complaining of what people call this chemo brain. You know, she feels foggy. She can't lose her key. You know, she's losing her keys. She's like, how am I going to go back to work if I can't even make it to the car without remembering my keys? And so for her, we just tried some really low dose methylphenidate, which is like Ritalin, both in the morning and at noon. And she felt like it improved her focus and improved her ability to sort of return to her sort of previously state of being. So these are just different things, different little tools you can have in your toolbox. Next slide. So we just came up with 5 pearls for incorporating palliative care into every day. One is consider a short-term use of baclofen. I think this is most commonly seen probably at patients at presentation and induction. Magnesium, super benign thing to try. A little bit of low-dose clonidine for those people who have generous blood pressures. And then a lot of it is just remembering the use of low-dose Ritalin or low-dose methylphenidate can really help with cognitive fatigue in patients, especially those that are going back to work. And I am mindful that it is 1:27 and we have about 8 more slides, but I'm going to go through the highlights for them because we do think that standardization matters. And we think it's really, really important to avoid implicit bias because that often dictates who gets a consult. So in our experience, it was pretty standard that we saw everybody who was in this study. Next slide, Amy. But with it being Juneteenth tomorrow, one of the things I learned from an AAP anti-racism meeting is that there really shouldn't be any talk that you give where you don't have some portion of it where you're really thinking about health equity and how we're going to address healthcare disparities. So this is a study that we did, which was looking at a national database of patients who had pediatric bone marrow transplant and inpatient consultation. Next slide. And this was just our data that found that we had a low rate of inpatient palliative care consultation. And when we looked at race and ethnicity, those who were Hispanic were much less likely to get an inpatient palliative care consult. Next slide, please. And then this just shows you that when we looked for our patients, we actually controlled for acuity. So when we looked at mechanical ventilation and malignant condition, they were more likely to get a palliative care consult. But when we looked at the Latinx population, that still stood out. Next slide, please. And so in our national survey of discharge data, so it was retrospective data, we found that mechanical ventilation, ICU transfer were indications for some people to get pediatric palliative care consultation. But despite controlling for acuity, Latinx patients were half as likely to get palliative care consultation. Next slide. This is important because we know that children who are in racial and ethnic minorities are also have a higher mortality. So they're less likely to get a palliative care consult, but they're more likely to actually die of their pediatric cancer. Next slide, please. And so next slide, we can skip this one. So we think it's important to keep this in mind because patients who are racial and ethnic minorities have a higher mortality and lower rates of consultation. So we just wanted to present this data to acknowledge and encourage every one of you, all 99 of you on the call, to just take a minute and reflect, especially the day before Juneteenth, what your own implicit biases are and how you allow your own perception of who you think is ready for palliative care decide who's getting a consult and who's actually getting aggressive symptom management. Next slide. And so we do think that integration matters. We do think that it can be done. I'm so, so, so grateful to Amy and Dr. Stock and Dr. Duvall and the whole AYA clinic for sort of welcoming our team with open arms. We did find that it is feasible to measure symptoms and quality of life, and that this joint model of oncology and supportive care clinic and young patients with hematological malignancies is feasible and at least anecdotally well received. Next slide. So we want to thank our amazing team. So Dr. Doherty, Dr. Stock, Drs. McNear, Henderson, Dr. Habaki. We have a lot of residents, medical students. The whole field of med-peds, I think, is really getting involved in this. So that's super great. We're super grateful for everybody's help. And then I know, I'm sorry, we're 1 minute and 22 seconds over, but we do appreciate this opportunity to present. I am really, really, really grateful for this. I'm really grateful for Amy and the AYA team. And please, if you have any challenges you want to talk about, I don't know if we have 1 minute for discussion or if you want to use the chat or whatever works.
Thank you so much for being so in tune to the time. I mean, this was a great presentation, and I had shared with both Dr. Hoehn and Dr. Wang that in my next life, I am going to be the marketing firm for palliative medicine. So thank you so much for starting off with the definition, because there is a lot of people need to learn and need to utilize and partake of palliative med. So let's do one question. Within the vignettes, you talked a lot about pharmacologic interventions for various concerns, including anxiety and inattention. Do you typically engage psychology providers for presentations with a psychological component? Are there ever times where behavioral strategies are the first line rather than pharmacologic interventions?
I would say absolutely. We're also incredibly, incredibly grateful, and we did not highlight this enough, that there's actually psychology embedded within the clinic. So all these patients are seen by Dr. Martins, who's the Peds Psych postdoc fellow. And so absolutely, we believe in non-pharmacological treatment, and all of that is being done by the psychologists embedded in the clinic. My role has focused more on the medical management of it, partly because we already have that very specific resource and strategy being addressed by someone else.
Excellent. Well, I want to thank you both for sharing the University of Chicago's work in this area and how you have incorporated supportive oncology, and for your research for health-related quality of life, which is so, so, so important to these young people with cancer diagnosis. Excellent. Thank you both. We really appreciate you being here today.
Thank you.
Thank you.
You're welcome.